Okay, Lorraine, I think Lorraine and Mark, thank you. I've let everyone in that it has been waiting. So if we want to get started.
Okay, I'd like to call the November 4th, 2024 PDASC meeting to order at 2:03 p.m. Christina, can you please call roll?
Yes.
Thank you.
Renee Bovell. Renee Bovell. Sean Brown. Sean Brown. Angela Bryant.
Here.
Thank you. Stephen Chen. Stephen Chen. Allison Siborowski. Allison Siborowski. Lorraine Diana.
Here.
Thank you. John Elliott. John Elliott. Okay. Sharita Golden. Sharita Golden. Jim Gutman.
Here.
Thank you. Darren Johnson.
Here.
Thank you. Nishona Kess.
Here.
Thank you. Greta Kessler.
Here.
Thank you. Barry Lipsy.
Here.
Joey Mattingly. Joey Mattingly. Eric Morse. Eric Morse. Mark Nicole.
Here.
Thank you. Sean O'Brien.
Present.
Thank you. Haley Park. Haley Park. Mandy Poplowski.
Here.
Thank you. Kimberly Robinson. Kimberly Robinson. Glenn Schneider.
I'm here. Thanks.
Thanks. Kelly Schultz.
Present.
Thank you. Sean Tunis. Sean Tunis. Joe Wynn.
I'm here. Good afternoon.
Thank you. Thea Williams. Thea Williams. Co-chairs, we have quorum.
Thank you, Christina, and thanks everyone for joining today. We appreciate your time that you spend on this very important subject.
I'd like to move on to get a motion to approve the August 26, 2024 meeting minutes. Do I have a motion to approve the minutes as drafted?
So move, Jim Gutman.
Thank you. And a second?
Second.
Thank you. All approve, say aye.
Aye.
Hi.
All opposed, say nay. I hear no nays, and so the minutes are approved as drafted. Thank you.
Christina, did we receive any public comments for this meeting?
Mark, we did not receive any requests for oral public comment. The PDASC received one written comment that was shared with the PDASC and posted to the website.
Thank you, Christina. Now I'll turn it over to Andy York to give a presentation on the upper payment limit and policy review process. Andy will also discuss agenda item number 5, regulations, in this presentation. This is the time for the PDAS to ask questions and provide comments and feedback on the draft regulations. Dr. York will provide his presentation before opening up for any questions. Andy?
Great. Thank you, Mr. Chair. Yeah, we have a lot of very exciting updates on our work since the last time that this body met, and we do appreciate everyone's flexibility. I know we originally had this scheduled for the end of October, and we appreciate the Stakeholder Council being able to move this to the beginning of November. So just for everyone's reference, you'll remember that on September 10th, the board approved the upper payment limit action plan and submitted it to the Legislative Policy Committee for approval. We presented before the Legislative Policy, thank you, Christina, for switching to the next one. The Legislative Policy Committee met and reviewed our upper payment limit action plan during a hearing on October 22nd. They received 22 comments and had a pretty robust discussion and a number of good questions for us as we made this presentation. And ultimately, they approved the upper payment limit action plan, which allows the board to move forward with their work. And so the next step for us or for the board is to adopt regulations establishing the policy review process that is outlined in our upper payment limit action plan. So on October 28th, we posted a draft of the regulations, and the purpose of this process is just to get public feedback and input on these regulations. So we understand that these are a draft. I think there's certainly some pieces of this that could change, and this is the chance for the Stakeholder Council to provide your initial comments or ask questions and help us clarify our thinking on this. But then also the Stakeholder Council members are welcome to provide written comment. Written comment on the draft regulations are due on Friday, November 8th. So you have the rest of this week to provide comments. And then ultimately, the board would need to publish final regulations that it would then approve to be published. And then if they're published, they go through the full notice and comment according to the Administrative Procedure Rules of Maryland. So I'm happy to go through that timeline if that's helpful. But right now we're at the process where we have a draft of these regulations that are trying to put the action plan into place. And right now we're looking for a comment, and we're trying to get as much comment as we can from the Stakeholder Council and any stakeholders out in the public that have thoughts for us. So the purpose of today's presentation is to kind of go over the regulations. I don't want to rehash the presentation that we went through last time. The regulations largely align with what we presented to you that was in the upper payment limit action plan. I'll go through the regulations as much as possible, but I do, and also try to point out anything that might be a little bit different from the action plan that isn't like a one-to-one tracking. And then there's a couple things that I think we're interested in just general feedback on as we think through the best way to work through some of the processes that I'll go through at the end of this presentation. So Christine, if you move to the next slide, we'll just give a quick primer on how regulations work. So when you see the COMAR citations, the first is the title, and we sit in Title 14 under the independent agencies. We have Subtitle 1, which is the Prescription Drug Affordability Board. And then we have a series of chapters that break up into different parts of our work. And then under each chapter, there can be a number of different regulations that kind of break down to the very minuscule level. Next slide. So as I mentioned, actually, Christine, if you don't mind going up 2 more slides to the regulations, I'm sorry about that. So this one. So just for everyone's reference, when we created this policy review process, we had to create 3 new pieces of regulations. So that's why they're published as 3 different parts. We made some minor updates to the definitions. So you'll see that as the first one. So minor amendments to the definitions. We created a new regulation in Chapter 1, which is the hearings process. or hearings procedures. And this sits in this part of the regulations because these hearing procedures will apply to all of our work. It's kind of an overarching regulation that we can use for a number of different circumstances. And then finally, we have the new chapter, which is kind of the meat of the presentation, which is our policy review and final actions and upper payment limits. So I'll go through each of these as just outlining the different parts of the regulations. Next slide. Okay, so you'll remember that in subtitle 1, we have 5 different chapters right now. There's the general provisions, there's Prescription Drug Affordability Fund, our Public Information Act, our cost review process, and this new policy review, final action, and upper payment limits chapter. Chapter. Next slide. And then, so I guess the one thing I'll say as we go through this presentation, I highly encourage everyone to read the regulations. It's difficult to kind of transpose them to these slides. And again, to avoid just kind of reading the regulations to you, we've kind of taken bits and pieces and the things that we think are worth discussion, but I would highly recommend that everyone that is interested in these regulations actually just read the PDF documents that we have posted on the website. And specifically for definitions, I will flag that I'm not going to read through the definitions. I'll just let you read through our new definitions. There are a few definitions that we needed to update and add just to apply our process for our policy review process and potentially setting up our payment limit. So I encourage you to go through there, and we do welcome any feedback on definitions. If folks think that we missed definitions, you're welcome to flag additional terms that should be received definitions. And then if you have technical feedback on the definitions themselves, we always welcome that. Next slide. Next, we have our hearings procedures. And this is, again, a completely new set of regulations that will apply not just for our policy review process, but as a tool that the board can use throughout their work. And we have a few different pieces. We have the scope, we have general hearing provisions, and then informational hearings and technical hearings. The one thing that I wanted to flag here is that if you read through the upper payment limit action plan, we do reference that as part of the information gathering, there's a couple types of hearings. There's informational hearings and then expert input. And we've rolled the expert input into technical hearings just so we don't have to make like a series of different rules for all kinds of hearings that are functionally they're gonna have the same structure and rules, that we just call them different things throughout the upper payment limit process. So the purpose of our regulations is to kind of set the standards and rules that we need to follow as we engage in these hearings. But so I just wanted to give you a heads up on that's why that's not a one-to-one tracking from the upper payment limit action plan over to the regs. Next slide. So I would just go back to the hearings. We don't have a lot to say on this. Again, I would just emphasize reading the regulations. If you have any comments or questions on them, please feel free. But again, this just kind of sets the ground rules on how we would engage in moving these hearings. There's not a lot of extra context to provide, but we welcome any feedback that folks have or questions or recommendations. So please do provide comment on the hearing section. So then we're going to move into the meat of the presentation, and these are our regulations on the policy review, final actions, and the upper payment limit. So that's the title of this new chapter of the regulations. It has these 9 different sections. First is the just definitions. So the definitions in this section are definitions that are specific to the policy review process and setting upper payment limits. The definitions that were in the overall or the general provisions that I had mentioned are definitions that apply to all of our work. However, there's a series of definitions that don't apply to anything, like are basically not terms that are only used in this process, and that's why they're in this definition section. We have the statutorily mandated criteria for setting upper payment limits, which I'll go through. We also then have the policy review and final action process. And then we do have the different sections that we've mentioned. So we have our overview in the 3rd regulation, and then we actually break down each part: the information gathering, the preliminary policy recommendations, and the process for establishing an upper payment limit, and then final policy action, how you take final policy action. We've also have 2 sections at the end that we're particularly interested in feedback on. So I'll go over those at the end of the presentation, but that's one thing where we think we can get a lot of really strong public comment that can help us think through those processes and steps. And that's establishing and monitoring the upper payment limit, and then also the process for reconsidering an upper payment limit. Next slide. So again, I find it easier to kind of try to stay at this very high level. So I'll start kind of just verbally describing what this process should look like. And then I'll try to map how our regulations kind of work through each of those steps in the process. Again, highly recommend reading the regulations. I think they are kind of a lay audience can work their way through the regulations. And I think that's by far the most useful thing to do, because ultimately what I say here is, my description of that, but the regulations are going to be kind of the law of the land. So whatever says in the regulations is what goes. So I encourage folks to prioritize actually reading the regulations themselves. So at a very high level, you'll remember that we had our cost review process, which basically, the board identifies drugs that are eligible, selects drugs for the cost review study process, analyzes the drugs for the cost review study, and then makes a determination on if the drug has or will lead to affordability challenges to the healthcare system or high out-of-pocket costs for patients. I'm saying that from memory, so it might not be exactly the terms in the legislation. But basically what this action plan proposed is, before that final determination in the process of determining if the drug has led or will lead to affordability challenges or high out-of-pocket costs, we are putting in a preliminary determination, right? So that's the identification of, like, is there a problem here? Does this drug cause affordability challenges for patients to access that drug, or high costs to the healthcare system? And this allows us to then try to figure out how do you address that, right? We identify the problem, but we don't understand, it doesn't necessarily explain why there's a problem or what to do about that problem. What this policy review process is basically tries to address that. It's what's actually happening here, right? The how the affordability challenge is happening, and then what can you do to address that affordability challenge? So basically the board can make this new preliminary determination. If they decide that the drug does not cause an affordability challenge, then there's no further action necessarily. They just make their final determination and publish it as the final cost review study report. If they determine that it may cause an affordability challenge as part of the preliminary determination, then we have this new process to, again, try to address that. What can the state do to try to make that prescription drug more affordable for patients in Maryland? So the first thing we do here in the yellow is we actually identify the drivers, and that's the why of the drug being unaffordable. There's a number of different kinds of market failures or reasons that may cause the drug to be unaffordable. And each of those reasons probably has a different policy solution. So the first thing we need to do is actually identify why that drug is causing the affordability challenges. And then if so, the board can then start to make policy recommendations to address those drivers. And we broke it up into two big buckets because it's an upper payment limit action plan. There's the upper payment limit process. You can go to the next one, Christina, that's fine. There's the upper payment limit policy options, and then there's the non-upper payment limit policy options. The reason we divided them is, again, the board has the authority to set upper payment limits for state and local government. And because it has that authority, it's important to have a much more robust process articulating each step, and especially defining where different pieces of the steps will be made public and available for comment, and the different processes the board needs to follow when setting an upper payment limit. But I would say just as importantly, and we mentioned this during the Legislative Policy Committee, is the non-UPL policy options. The reason they get a much less ink put into that is just because all of the recommendations for non-UPL policy options are ultimately recommendations from the board to other entities within the state that is kind of outside of our direct authority. It's recommendations from the board that should carry weight because it'll also have kind of the background of why these policy options are the right ones, and the issues that they're actually trying to address. But I would emphasize that the board will be looking at all policy options that are available and putting a lot of emphasis on these non-UPL policy options. I guess, and I'll just verbally walk through the steps really quickly, and then you'll see how they actually apply in the regulations in just a moment. Okay, so just starting with the non-upper payment limit policy process. These two processes happen in parallel with each other. So there's no direct rules on like when certain meetings have to happen when, and we can address multiple topics. You can address UPLs and non-UPLs in the same meeting. So it's difficult to actually like sequence them, but they are supposed to be happening at the same time. So the first thing you need to do is, again, the board staff, the board members and staff will identify the drivers of what's causing the affordability challenge. And then they will ultimately make recommendations on policies. And then there's different rules for if you're recommending non-UPL policies or upper payment limit policies on exactly what needs to be articulated when you recommend those policies. If they make non-UPL policy recommendations, again, we gather information for the policies. Then the staff identifies the drivers that cause the policy, identifies the drivers, and then identifies policies that address those drivers. The board ultimately provides feedback. The staff can update our recommendations and propose draft resolutions for public comment. And then ultimately the final action is that the board adopts resolutions, basically putting these recommendations in place for non-UPL options. At the same time, the board can be working on UPL policy options. So if the board identifies the upper payment limits as a policy option that they want to move forward with, the staff gathers information for implementing an upper payment limit. The staff will then recommend a UPL. The staff says, yes, we should do a UPL, and it recommends methods. And in our regulations, we outline a number of different methodologies that you can use. Again, the different methodologies kind of address different market circumstances. So not that, every methodology isn't always available for every drug. And then also, depending on the drivers that the board and the staff have identified, you may want different methodologies to address those drivers. So that's why the staff basically says, yes, we should do a UPL, and here's the methodology we recommend. At that point, the board can provide feedback to the staff. They can say, yes, we agree with your recommendation, or no, you should use this methodology instead. And also, sorry, I should also say that the staff is going to publish that for public comment as well before it even goes to the board. So staff will publish their recommendation, and then also the methodologies and the context that they should be considering when they set that. We'll receive public comment, and then all of that will go before the board, and the board can kind of give direction to the staff on how to on the next step. Then the board will ultimately say, okay, staff, we agree with all this, and we've given you your necessary feedback. Actually calculate the number. So then the next document that the staff will publish is a draft of the actual calculations and methods that are used. And the purpose of this document is to actually show the work of how we were coming up with an upper payment limit amount based on the feedback that we've received from the public and the board. And again, this is ultimately open to public feedback as well. And we expect a lot of very technical feedback at this step in the process. We'll be opening up our full methodology, the assumptions that we're making, and we expect to get feedback on kind of every element of how we're making that calculation. At this point, the board may host technical meetings. So again, because we expect the comments to be so technical on some of the calculations and methods, the board can actually host these technical meetings that we've referenced in our hearing section to work through some of the technical issues that have been proposed, right? A lot of these are kind of talking through different assumptions you can make, rationales for why you would build a model one way versus the other, specific, critiques or recommendations around, how to actually make the calculation. So there's a number of different things that we can receive public comment on or technical comment on. And sometimes it's easier to, host that in a hearing versus requiring written comment and just kind of going back and forth. So that's the purpose of that step. And then ultimately the staff can take that information and update the methodologies and calculations and recommendations. If we make any changes, we will always publish a draft version of the document for public comment, right? So any changes that we make, we would publish an initial version, set some period of time for public comments, and then ultimately there will be a point where we take the public comments, there are no additional changes, and then that entire packet is basically brought to the board, and then the board can take final action, which is adopting the UPL as a proposed regulation. So all the upper payment limits will be done as regulations, and we'll go through the full comment and rulemaking that we have as part of our Administrative Procedures Act. So that's ultimately how these two separate processes can work. We do picture the final action for the non-UPL policies and the UPL policy that happen at the same time And you'll remember that we used to have a red line underneath, which was our final cost review report. So the first thing that needs to happen is the board needs to finalize their cost review study report that says this drug causes these affordability challenges and we recommend these policies, right? Then in that same meeting, the board can then say, and we adopt these resolutions that recommend these non-UPL policies to address this. And in that same meeting, they can also say, and the board adopts this UPL as this proposed regulation. So all these things can happen in the same meeting, and that's kind of how we picture the process to work, though there's no requirement that they necessarily happen in the meeting. All that needs to happen first is that the cost review study report needs to be finalized before you can make policy recommendations. So that's the overall gist of what we're trying to do through these regulations. And now I'm going to go very quickly through the actual regulations themselves. Again, our intention is for the regulations to track the process that I articulated. So, I would encourage you to, again, to read the regulations and make sure that that tracks, what you heard and what you understand for how the process is supposed to work. So again, going just quickly through these, we do have the definition section. So it does have definitions that are specific to the policy review process. So for example, we define upper payment limit. This is from our action plan, which means an amount established by the board that an eligible governmental entity cannot exceed when purchasing or paying the ingredient cost for the prescription drug product after all price concessions, discounts, and rebates. So again, that gets at the idea that we're trying to get at the final net ingredient cost, not including dispensing fees or anything like that. So that's just one example. There's a number of definitions that I encourage you to read and provide feedback on. Next slide. We also have our statutorily mandated criteria for setting upper payment limits. I'll let you read through these. These track what was in the upper payment limit action plan, but it has a series of things that the board will do and that the board will not do. So I think you can just scroll through these, Christina, if that's okay. So the board shall do those things, and it shall not set an upper payment limit if, and then it has a series of conditions that are articulated. Again, this should track directly to the upper payment limit action plan. Next slide. Next, it goes through the overview of the policy review and final action process. So again, it articulates that we have our information gathering, and we have these different tools that the board can use to collect information to ultimately make their policy recommendations. You can have your preliminary policy recommendations for policy action, and then we differentiate between UPLs versus non-UPLs, and then also the final actions. And the final things that we need to do are the adoption of a final cost review report, and then the adoption of non-UPL policy recommendations as resolutions. And then also the board can adopt a proposed regulation setting a UPL amount. Next slide. So just going through our informational hearings, information gathering, we do have these 5 tools. As I mentioned, our technical hearings include our expert input that we had talked about before, and then we also have our separate public informational hearings. Those are the 2 types of hearings that we've articulated in the hearings section of the regs that I mentioned above. Also, stakeholder council input. As you know, you're an advisory body that provides very important insight and input to the board, so you can provide that feedback, and then board staff analysis and research. And then we're also, since our upper payment limits are specific to eligible governmental entities, we do have a mechanism to work with them to get information that may help us work through the process. Next slide. Then all of that information can be used for preliminary policy recommendations, and that can include an upper payment limit and or other policy recommendations. And all of this is meant to be published for initial kind of feedback. Next slide, Christina. So we have our separate process for policies that are not UPLs. So the staff can recommend the policy options to redress affordability challenges. And this is one thing I do want to point out. Anytime the board is making specific policy recommendations that are not upper payment limits, the staff may analyze the drivers of the affordability challenges, the policy that addresses the driver, the strengths and weaknesses of the policy, possible implementation of the policy, and then potential impacts of the policy. So this goes to the point that we do expect that these resolutions and recommendations that the board makes will carry weight because of the background and analysis and supporting evidence that we will provide for those. So we do expect each of these, each policy to be well explored and analyzed for feasibility and working through the actual things you need to think through in terms of implementation. So it should be more than just a states should do blank, right? It's going to say, here's the very specific policy that we recommend. Here's the strengths and weaknesses of it. Here's why we recommend it, and then like an assessment of the actual policy itself. And then ultimately, the board may adopt or modify the policy recommendations, or they can ultimately add their own as well. That's within the board's purview. And then the board may ultimately adopt a final policy recommendation only if after the board's made their final has adopted the final cost review study report and made the final determination of an affordability challenge. Next slide. So then we have the entire process specifically around the upper payment limits. And again, we hope that it reflects kind of the high level summary that I provided. But first, the staff may recommend the upper payment limit as a policy option that can redress the affordability challenge. So there's that initial kind of recommendation that yes, an upper payment limit is a policy that can actually try to address these affordability challenges that we've seen. And then when recommending the upper payment limit as a policy option, the staff may analyze the drivers and market conditions causing the affordability challenge phenomena, the ability of an upper payment limit to address these issues, relevant regulatory criteria, and the use of the drugs by the governmental entities. And then the board staff may provide recommendations to establishing the upper payment limit that include an assessment of the drivers of the affordability challenge and the extent to which the upper payment limit may address those drivers. So again, this gets to the point that the board and staff will be trying to, it's no guarantee that if a drug is found to be unaffordable, that an upper payment limit will be set. The board needs to separately make the determination that the upper payment limit is one of the tools that can actually address this affordability challenge, right? We want to make sure that we're using the right tools for the right problems. So that's the first step of the board. And then the board may pursue the development of its upper payment limit as a policy option and direct board staff to provide recommendations concerning the methodologies and contextual information that may be used to set an upper payment limit. Next slide. So the next step is for the staff to recommend methodologies and contextual information. We've provided a list of methodologies in the regulations. We encourage folks to look at those different methodologies and provide insights into whether or not those are appropriate descriptions of each of the methodologies. And then we also listed the contextual information from the, and again, these are different factors that you may want to use almost as like adjusters for a specific methodology. So all of these are listed and articulated in the regulations. Christine, if you want to go to the next slide, I forget. Yeah, so you can see that we've actually listed out and do have language in the regulations for each of the different methodologies listed here. If folks think that there are additional methodologies that should be considered, now is the time to add those. And then ultimately we can do a blend of methodologies as well. But this is meant to be kind of a comprehensive list of all the different ways that the board can come up with an upper payment limit. And again, some of these methodologies are only relevant for different market circumstances. So just as an example, we always point to the therapeutic class reference pricing. If it's a first drug in class and there's literally nothing to compare it to, you can't use, those kinds of reference pricing items, right? So you would need to look to some other methodology. So that's why we have so many different methodologies available. But these, so the staff will kind of go from this list and then make a recommendation on which methodologies make the most sense based on the affordability, the drivers of unaffordability that they identified in the first step. Next slide. And then we have our contextual information. So again, these are the different factors that the board may want to consider that they would weight that can drive a methodology in one way or another, right? So just looking at 12, for example, if a drug is very late or early in its life cycle the board may say it's worth us paying more for this drug to ensure that they are able to recoup their investment and incentivize further research, even though one of these methodologies says the number should be blank, right? So that's just the way that they would use these different contextual information. So again, staff will kind of make their initial recommendations, and then we welcome public feedback on those initial recommendations, and the board will ultimately decide the methodology and the contextual information that's most important for setting the upper payment limit. Next slide. So then once for the upper payment limit values, the board can select one or more of the methodologies and contextual information, identify another methodologies, and prioritize the selection of methodologies and contextual information, and then direct staff to actually make the calculation itself, right? So there's going to be a board meeting after we've received public comment, and the board is going to kind of weigh all of that information and then tell the staff how to think about using the methodology and actually applying the methodology. And then based on this, the staff will then post a public version of the upper payment limit values that were developed through the analysis and the recommendation of a proposed upper payment limit amount with the description of the calculation analyses and relevant underlying assumptions. And then we must request public comment on the board's website. Next slide. So again, we have technical hearings. So we may convene technical hearings for the purposes of receiving technical information or expert testimony. And again, this is in response to these calculations that we plan to publish, and they may be very technical feedback that we want to have, and it'll also allow for kind of more engagement with the experts and the technical feedback folks that we'll be working with. Next slide. So then there can be updates to the recommendations and upper payment limit values. And then you can go to the next slide as well. And then ultimately, there's going to be the final policy actions. There's the final determination concerning affordability challenge, and then final policy action, which is the policy recommendations and proposed regulations. Next slide. So we don't have anything else on those. So ultimately, if you read through those regulations, basically the board again can vote on. First, the board needs to finalize the cost review study report and the determination of affordability challenges of the drug. So that's the first step. One thing to note is that can be different from the preliminary determination, right? The board can make a preliminary determination that the drug may cause affordability challenges, and then based on all the work that they've done, may find out that actually we misunderstood the circumstances. We got more information. The drug is not causing an affordability challenge, right? The final determination can be different from the preliminary determination. But the board first needs to finalize the cost review report, which includes the finalization of the affordability determination, and then they can take their final action that we mentioned on the upper payment limits and non-UPL policies. Upper payment limits, the board would publish regulations that articulate the upper payment limit itself. And again, that goes through full common rulemaking. So they will publish the proposed regulation. It will be published in the Maryland Register, and then they would ultimately for public comment, and then we would ultimately publish the final regulations before they can become live. And then for the non-UPL recommendations, again, they can vote to publish resolutions that kind of articulate the recommendations for the non-UPL actions. Next slide. Two things that we are interested in feedback on is the establishment and then also the monitoring of a UPL. So as I mentioned, the establishing of a UPL is going to be done through regulation. So this part of the regulation talks about how we would adopt a proposed regulation that sets the UPL and the information that would be included in there. And then also the board in the action plan talked about our monitoring plan. So the regulation requires that we're going to develop a program for monitoring the availability of prescription drug products for which it sets. And so right now the board is kind of thinking through and working through what that monitoring plan will look like. I think this will probably be a topic of a future meeting, but we're looking at different kinds of passive monitoring, right? So where folks can report to the board of different availability issues, and active monitoring, where we do surveys of different, pharmacies and other entities within the supply chain to identify if there's any availability challenges. Right now, our regulations just require that we put this plan into place, but we will be working over the next series of meetings, kind of establishing that plan, and we do welcome any feedback that folks may have on how to monitor the upper payment limits. Next slide. The last thing that we've put into the regulations are our reconsideration process. We have a series of things that we can do if the board wants to reconsider an upper payment limit. So if you go to the next slide, following the completion of, at any point the board can reconsider a UPL. And following the completion of the reconsideration process, the board may take no action and allow the UPL to stand. It may modify the UPL amount and propose an amendment of the UPL regulations setting the new modified UPL amount. It may suspend the upper payment limit for a specified period of time and propose an amendment of the regulation to prescribe the suspension. And then finally, it may repeal the UPL and propose repealing the regulations setting the upper payment limit. Next slide. So these are kind of the four buckets of how what the board can do when they're reconsidering UPL. The different steps in the procedures are a notice and then a solicitation of patient and stakeholder feedback. So we have written comment and informational hearings. We have the informational gathering process, and then the staff can present to the board for reconsideration, a summary of the feedback, summary of information through the monitoring program, and then the estimated impact of the UPL to date, and the staff recommendations, and then the board may take action. Next slide. The board can also recommend further study to support the modification and can use the process, some of the steps from above to develop a UPL amount and receive public comment. And then the board may modify the proposed amendment and propose an amendment to actually modify the UPL itself as outlined here. Next slide. And then it's important to note, it looks like there might be a typo. Okay, but no, this is right. Okay, so the one thing we also wanted to note is that, so one thing I should say, the regulations specify the difference between an FDA shortage, which is actually in our statute. So if a drug is on the FDA shortage list, the UPL is suspended, and then the board can take further action based on that. But our statute requires that we not set UPLs on drugs that are currently under shortage. So we do have a mechanism in the regulations to address that issue that I recommend that you review. And then what this is looking at is something that's kind of a little bit of a broader definition, right? So this is looking at, I guess, state availability or shortage issues might be the best way to articulate, as well as any other reason that the board may want to reconsider the UPL. So I did just want to note that there's the distinction between what our statute has on FDA shortages and then the general affordability or availability issues that the board may want to consider in any of their other kind of actions around a UPL. The last thing I wanted to point out is that if a UPL is repealed, the way that this process is set up is that basically if the board wants to go about setting an upper payment limit on that drug again, they almost have to start from scratch, right? So that drug has to go through the entire, it has to be selected for a cost review study, has to go through the cost review study process. If they make the preliminary determination that the drug causes an affordability challenge, they can then start to incorporate all of the work that they had from the previous cost review study report. So that's basically everything through the policy recommendations on the first round. But there isn't really a shortcut here. If the board repeals an upper payment limit, it basically kind of puts that drug back into the pool of eligible drugs if it stays eligible. Like actually, they need to ensure that the drug does stay eligible. And then it would have to go through the whole process again before it was subject to a UPL. So I did want to kind of make that note as a specific point. So I know we've thrown a lot of information at you. If we go to the last slide, I think I can take a few comments and we welcome any feedback or discussion that you guys have. But again, I would just end by saying, one, please read the regulations themselves. Those are ultimately, the language that has, that is the real language and enforces what we're going to be doing. And then also we very much are looking for feedback. So this is kind of, again, the draft regulations, and there's a lot of opportunity for folks to help us improve the regulations and, you know, improve the processes. And that's what we're looking for. We're looking for as much feedback as we can get at this step in the process. So with that, happy to take any questions that folks may have.
All right, thanks, Andy. Any questions? I see one hand up. Kelly Schultz.
Yeah, thank you. And in the spirit of Andy, your last remarks that you appreciate any feedback, I hope that I'm taking that in the realm of like sincerity, because I believe that there's many members of the stakeholder council that has given feedback in the form of public comment and stakeholder comment, and we've received no feedback on our feedback. So I guess, well, I intentionally for the last 45 minutes kept my hand raised because I was told that you wanted to wait until after the presentation was completely finished, now that we have 12 minutes left of the meeting, to take any questions. And I would think that this would be a great time to get feedback and to have some discourse, some dialogue about some of the questions that are in here. And I also appreciate that I did listen into the board meeting last week, and I understand that you don't quote unquote want to rehash the conversation that you had with the board last week, but I would dare say that this is a very important group to rehash what was said and was spoken about at the board meeting, because we are the stakeholder council to that board. That being said, I'm going to go way back in the beginning of the presentation, because that's when I raised my hand. And that was on COMAR 14.1.1.6. So basically it is the hearing procedures and the differences in the documents between the hearing procedures of informational hearings and technical hearings. So that would be on page probably 3 and 4. And there's different criteria as to what the chair may or may not do. And for those of you that are reading from your regs and have printed them out, it's section E2 and section D2. And on E2, with informational hearings, I'm concerned about the time constraints, because there's nothing listed there as to the amount of time that anyone coming to the hearing would have the ability to present for longer than the very minimal 60 or 90 seconds that they have during the board meetings. And I think that that's a really important aspect to add into that section, allowing somebody at least the 3 minutes that the legislators allow for their speakers. And then on that same section 2B, the chair or staff designee shall give all persons who register to speak an opportunity to do so, but may limit repetitious testimony. And I have a problem with that. If somebody is going to register to give information at a hearing, everybody should be heard, regardless of who thinks that it might be repetitive, but it is their right to do so. So I would suggest that be changed. And in that section C, 2C, the chair or staff designee, and it says may allow questions from the audience. And throughout all of those subtopics below that, I have a problem with the word may in there. So is there an instance where a chair or staff designee would not automatically ask questions of anyone present at the hearing, or refer questions to the board, or take questions from the audience, or allow questions from the audience? So perhaps that could be re-examined in true transparency as to how the hearings are going to unfold in the future, which I think are really important, even for the informational hearing part. And so then as that transfers over into technical hearings, I would say that section 2 of section D, technical hearings, there's a different process as to what the chair again may do, and it eliminates questions from the audience and other people that are there to provide input. And curious as to why the same information wouldn't be gathered at a technical hearing as opposed to an informational hearing, understanding that some of the content may be a little dissimilar. And then obviously something that I have written about several times in feedback letters that I've received, still no communication on from the board or the staff, is the final record of the hearing record, and that is in section F. I would like some readjustment to what would go into the final record. It says that there may again include things like a full or partial manuscript. I think that we have to be as transparent and open and publish all of the information that happens at these hearings in a way where they can be easily accessible by anybody that's doing the future work on that. I don't know if you have the time to respond to my feedback that I spent some time putting together, but would love to know that that would be taken into consideration by both the staff and the board.
Great. Yeah, no, I would, one, thank you. This is all great feedback. And we are very sincere when we say that we're looking for this feedback. Couple points. One, our meeting goes till 4, though I do want to be respectful of folks' time. So we do expect a lot of feedback. Like, this is the correct form for that. So thank you for bringing that up. Okay, so in terms of the public comments, so the board does review and receive all public comments, and we have, I think, made substantial changes and significant changes based on the comments that we receive. I would say just in general, when we are getting comments, if the things that are most actionable are when folks can propose, like we understand when folks are saying, I don't like this. If you can propose an alternative, I think we are very, very receptive to that. Otherwise, you know, when we're thinking of alternatives or the solutions to the problems that you're identifying, you know, ultimately we're doing the best we can. So I would accept that. So going into your specific recommendations, which you did have very specific recommendations, which were very helpful. A couple things. One, I would say I think what you've pointed out is an artifact of the fact that we were trying to use these rules for any kind of hearings that the board would want to do. So we've intentionally left some space there in case different kinds of hearings kind of have different formats. So just as an example, we've talked a lot about listening sessions, and our regulations don't currently afford the board to, there's no mechanism to do it under our current regulations. So we were planning on doing things like listening sessions under these same hearing rules that we would for, you know, direct public comment on specific issues, right? So that's kind of why they are written this way, to give us the flexibility to have different kinds of formats and purposes for these different informational hearings. We are, you know, I did hear you say that you want to put some sort of guardrail. So, for example, you mentioned the 3 minutes. I can picture scenarios where we wouldn't want to limit it to 3 minutes, and I guess it's always within the board's purview to give that up. But that's why we didn't put things like specific timelines or anything like that. I think, again, the purpose of these hearings are to be more flexible than probably what we've seen in other circumstances, right? So we want to use this as a tool to get more information and feedback from different stakeholders. The issue around limiting repetitious testimony, I think that's a good point. I think we can certainly take that back. I don't see a direct reason to not do that, other than just respecting the time of everyone that is in attendance. But to your point, if someone's taking the time to make those comments, we should also give that respect to them to hear those comments. And then may allow questions from the audience. I think this is kind of just a meeting hygiene issue. I think if we will think through the best way to manage this, because we understand that folks from the audience may have insightful questions that may be helpful for clarifying and you know, helping us get additional information and providing insights. But you can also picture scenarios where that could become unruly if there's no kind of guardrails or guidelines on it. And the way we've structured it is that the board chair provides those guardrails and guidelines on it as the chair of the meeting. So I think those are all good comments. I would certainly welcome those to be, please submit them. We will collect them now as a input from the stakeholder council, but if you also want to supply written comment, I think these are all certainly things that we would talk through and try to address. Technical hearings. The last thing, in terms of what goes into the final record, we welcome that. We understand that everything we're doing should be publicly available and as accessible as possible. So we can double check the language there and just make sure that is articulated. You know, part of what the final record is also, it has kind of like cost implications for us. So for example, if you are having some sort of like certified transcript that has some, you know, there's reasons why certain tools are more expensive than others. And if that has cost implications, we just want to be thoughtful around that. So I would just say we support and echo the feedback that we want this process to be as transparent as possible and as open to the public as possible. And we'll see what we can update around that. So yeah, thank you for those comments. That was great. Let's see, Dr. O'Brien or Mr. O'Brien, it looks like you were up first.
Yes.
Then Dr. Tunis after that.
Yeah, definitely not Dr. O'Brien. So this goes to sort of the definition of UPL terminology used. So if you go to 08, so jumping ahead to 08A3, which refers to the final net ingredient cost paid by the eligible governmental entities. I may have missed it, but I haven't seen a definition of either final net ingredient cost or net ingredient cost. I guess it's sort of described in, what would that be? 05V6 definition of the upper payment limit. I would note there is I think there is in existing regs, there is a definition of net cost. So I don't know if there's meant to be any differences there, but I'm just pointing that out, right? And maybe you want something that you may want to tighten up, either by providing an explicit definition of net ingredient cost or doing something else. Related to that is sort of more of a question, given the way this is framed, and it's more of, sort of what's the reason to believe that somebody in the system here couldn't try to recharacterize something as a non-ingredient cost that essentially evades the upper payment limit. And maybe I'm just sort of trying to imagine things that aren't possible, but that certainly would be a concern. I know that's often a problem just sort of generally in pricing issues. You can recharacterize something as some other kind of payment to make up for some other limits on payments. So I'll stop there. Thank you.
Two great comments. So that's exactly what we're looking for. This is very helpful. So we'll take a look. I don't have a direct answer, but I see where the confusion come from. So that's a great comment. So we'll take a closer look at that and see if we can flesh out the clarification there. In terms of non-ingredient costs, so maybe the solution is to come up with a definition for ingredient cost, but I do think there's a potential, like one thing that could happen is more stuff gets shuffled into the non-ingredient cost. Whether or not, I think the ingredient cost is going to be an easily definable feature, but then the flexibility that we have around non-ingredient costs, I think, is certainly something that we should think through. I think it's currently intuitive under the current system of dispensing fees and things like that. So it is a current universe, but it's a great point that universe could expand as a result of this work. So we'll certainly either put that into the monitoring plan or see if there's anything we can do around definitions to put some guardrails in.
Thank you.
Thank you. Great comments. Thank you. Dr. Tunis?
Yeah, hi. Can you hear me okay?
Yeah. Yep.
Oh, yeah. So yeah, Dr. York, just wanted to first, kind of applaud you and your team and the PDAB for how much progress you've made in a short period of time. So pretty incredible. And I appreciate the complexity of the task. Sort of two related questions. One is, I'm wondering that the term as one of your tools of domestic reference pricing, was imagining that would include reference pricing to the CMS negotiated prices through their mechanism, and whether there was any thought or discussion of sort of any kind of expedited process for kind of the regulatory approval of that, or whether it would sort of be packaged in with the regulation for all the other drugs that are not under the Medicare negotiation scheme. And just kind of related to that, just so you can answer both, I was wondering if there was going to be a fixed timeline for the upper payment limit, or policy recommendations, in terms of a regulatory timeline, be an annual, on an annual schedule, or it would be kind of ad hoc, or how that was going to work. So those two questions, one related to CMS negotiated drugs and the other just timeline for the regulations.
Yep, great questions. So first one, the CMS maximum fair price. The way we would picture it is being in that bucket of domestic reference prices. So I don't think it necessarily gets any special treatment, though the board, and staff, I guess, on the front end can recommend to weight that more or less than other reference prices that it's looking at. There is no kind of expedited process. And to your second point, so I think we would follow all the normal steps, even if you are heavily weighting a certain domestic reference price. But that also gets to the point of there is no fixed timeline on how long this process takes, just because certain methodologies take more time and resources than other methodologies. So just as an example, if you're doing some sort of comparative effectiveness, study, like, de novo, first drug in class, you have to come up with everything, and there's very little literature available, no, reference prices to look at, and all you're doing is kind of looking at things from scratch. That's going to be a very time intensive and resource intensive process to kind of make it through those steps. Whereas if something's been on the market for a long time, a lot of comparable drugs and all that stuff, it's just it's a different process basically. So I don't think we would put any kind of fixed timeline on setting up for payment limits or the policy recommendations. I think we get the general sense, we've, I think, seen this in some comments where stakeholders want some element of predictability. So right now, everything is ad hoc, right? The board at any point can identify drugs that it wants to enter into the cost review study process. So that's an ad hoc process. And then we go through the process for as long as that takes. And this policy review process is kind of the subsequent step or one of the final steps in that cost review study process. I think as we better establish the process, we can try to standardize it and create timelines as much as possible, including, at this point in the year, we always do, this is where we select the drugs for the cost review this year, right? Like you can standardize that. At this point, I think the board is currently just working through the process and seeing how long it takes to even be able to, make those kinds of estimates and recommendations. Let's see. And then the last thing I did want to note just as part of your comment is the regulation. So if a board decides to do upper payment limits, posts a proposed regulation, there will likely be some sort of element of timeline associated with that as well. So just because the regulation is published, that will include an effective date, and that doesn't necessarily mean it's the effective date that the regulation is published. We'll be working with each of the eligible entities that will be subject to the upper payment limit to identify when the upper payment limit can be implemented for them. So you can actually see a scenario where each regulation has, 3 separate timelines for 3 separate eligible entities, just because that's how, their process works, and that's where we can kind of fit in to that. So all that would be kind of articulated in the regulation, and I'm not sure if it would even happen in the regulation or if it happens subsequently, but there could be different, because we're doing this through contracting, through the existing contracts of the board, the timelines can look different for different entities.
Yeah, no, I appreciate those answers, and again, appreciate all your work. And I know a lot of folks are eager to see you continue to move along at pace. And if there are any, well, I don't know what to call them, shortcuts, but just to the extent it can be expedited, particularly for drugs like that have an established maximum fair price, seems like worth considering. But again, you're probably discussing that, and I appreciate your answers.
Great. Thank you. Dr. Popowski.
Good afternoon. Thank you for going through the process of the policy review. And I had some questions regarding more content in the regulations and just maybe some feedback and suggestions as I was reading through. First, it might be a little bit similar to comments already made by Sean, but I feel like some of the definitions of net cost are a little bit unclear just based on some of the language where there's, language in the definitions around prioritizing drugs that have a high proportion of out-of-pocket costs compared to the net cost of the drug. Yep. So is the net cost definition meant to include the patient cost share or not? Because I think that could have a different impact on how the UPLs are applied or the impact of the UPL, particularly members and, high deductible, and different product designs from the health plan. So just not sure if there's an opportunity to revisit that definition or add some clarity if the net cost is meant to include member cost share or not.
Great comment. Thank you. Yep. Wanted to address that.
Secondly, in the criteria for setting an upper payment limit, you talk about minimal utilization, or there's language about minimal utilization.
Yeah.
That also just seemed a little bit ambiguous, and I'm not sure if it needs to be more clearly defined. Where you say that the utilization of the prescription drug product by the eligible governmental entity is minimal, and that's the scenario in which the board would not set a UPL. That could be interpreted, I don't know, just when I was initially looking at it, does that mean like minimal as the number of patients taking the drug? Is it minimal from drug spend? Is it both?
Yeah.
If you think about specialty drugs, very minimal utilization, but high cost. So just, a recommendation there around minimal, if there's an intent behind that and a way to clarify.
Yeah, we did receive a lot of public comments on this. The issue is that it's hard to come up with some sort of threshold. So we welcome we would love direct recommendations here. So basically what we're trying to get at with like the thinking behind this criteria is basically when we're doing a cost review, it's based on, we can look at eligible governmental entities, but especially up to this point, it's been for the entire state. Our cost review is done at the state level. So the board has identified drugs that have kind of high level across the state, but the upper payment limit is a very specific tool that applies to eligible governmental entities. So we were wondering if there's, or there may be scenarios where, it looks like it's causes affordability to challenges to the state. But for example, like Bureau of Prisons they don't use that particular drug for their patients, right? They have a very specific formulary and it's just like not even on that formulary. Then there's no reason for them to implement an upper payment limit for that product, right? I think conceptually the idea is like if it takes more time and resources to implement the upper payment limit than you would get from savings from implementing that upper payment limit, like I think that's like one way you could think about it, but it's tough to kind of put that in a definition. And it is difficult to set the threshold specifically because of what you mentioned, right? If you say it's less than 5 patients, well, if you have 5 patients on this, gene therapy or specialty drug, it's actually a super important drug, and that's actually the entire patient population, right? So that's the struggle that we had there, but we are very receptive to the comments that we received, including yours. So if you have recommendations there, we certainly take them, but I do think it's going to be a principle and criteria that the board uses when deciding to implement an upper payment limit for specific
Yeah,
entities.
and I appreciate that feedback. And I wasn't thinking of setting like a number because I do agree with you that that's difficult, but I was thinking more of the lines where you're talking about like minimal utilization, maybe setting some guardrails. Is that based on number of utilizers? If you're defining utilization very, concrete, or is minimal going to be defined as from like a spend, or maybe even both? So maybe just categorically thinking about how to define it. But yeah, I do agree, like setting a number threshold will be very difficult because I think it does depend on the cost of the drug. And what you like the number of patients that could be impacted.
Great. Yeah, I appreciate the comment. Yeah, thank you.
Yeah, and a couple more things that I had just as I was going through it. Again, in I think it was section .02 under the criteria for setting the UPL. I just wanted to know if there was a rationale when you mentioned that a UPL will not be set if the prescription drug product is a generic and there are 9 or more therapeutic equivalents for the product. If that 9, there was a rationale behind that 9, because I feel like an entry of usually around 3 to 4 generic equivalents is at a point where you would tend to get max generic savings. And just more of a question for me of like 9, it seems like then you might be, never setting it or having more opportunity to set UPLs because 9 is a high number.
Great question. And there's a lot of this, there was a lot of discussion on this specific one. So the general principle that we're getting at is if there's enough market competition, there is no reason to set an upper payment limit. If market competition has kind of, gotten the drug to commodity pricing, then an upper payment limit is not the correct tool to address this. So I think you're right. I think the literature kind of says that 3 to 5 range, as soon as there's 3 to 5 drugs meaningfully on the market, then you've kind of reached the steady state of what the generic price will be. I think the concern that came up from discussion, I think in the board meeting, was just that you want to make sure that it's not gameable either, that you have kind of, I don't want to call them like generic drugs that have so small of a market that they actually don't provide meaningful competition. And then you also have folks cycle on and off, and then you also have generics that are approved that may never make it to market. So that's why we do use that market language. So I think ultimately the reason we went with that, so I think what we see in the literature is kind of that 3 to 5 range. But then the board wanted to bake in extra protections to make sure that there is no kind of opportunity to gain that. And that there really is a full competitive market for that generic drug. If there's a better number, we welcome it. I don't think anyone's particularly tied to 9. I think they just want to make sure that there's full saturation of generic competition, basically.
All right, thank you. 2 other quick comments. Again, here in section .02 for the criteria for setting the UPL around the Medicaid best price.
Yep.
I just have questions around like the impact of a UPL on, any impact to statutory or regulatory amounts such as the Medicaid best price, and like not sure like if UPLs are implemented and they are effective, would there be an impact to that Medicaid best price and driving that down? So again, you're saying like there wouldn't be an impact, but in theory, I think again, just something to think about.
No, it's a great comment. And again, we got some really insightful public comment letters on that. That's something we're exploring on the staff side, and I don't have a direct answer on. I think the high level principle that we've been talking about is like, that there's the 2 ways that you come up with the best price. There's kind of AMP and then some like, adjustments to AMP, or if it's lower than that number, the formulaic calculation, which we can't see because all of these are numbers that live within CMS and we don't have those numbers. But if you are lower than that, then the Medicaid best price is that price, right? So I think just in our casual discussion, we wanted to make sure that we are never that price that kind of sets the lowest Medicaid best price, basically. So you don't want to be lower than whatever that formulaic output is. But you bring up a bigger point of like, do sales feed into formulas and blah, blah, blah. Like, can you I think it brings up good points and something that we would think through. So,
and maybe that becomes part of like I don't know if it becomes part of the monitoring plan, right?
Yeah.
Because I would think in my comment, if like, your UPLs are effective, then to your point, the way the formulas are calculated, could it end up driving down that price, and how frequently is that reevaluated? And then the last thing I'll just wrap up on, and just like section .08 around enforcement. I know you mentioned Andy, in kind of your presentation, that there will be, a monitoring plan put in place, and I think there will be regulation that might come out afterwards. Just, I felt like there was very little guidance in the draft regulations around the enforcement mechanisms to make sure the UPLs are implemented and followed. So I'd like to see kind of more regulation around that and monitoring procedures. Because in order for the board to be effective, it has to be implemented, and it has to be adhered to by all of the stakeholders. So just curious to see like more language and regulation around that.
Great. Yeah, I'll flag that the enforcement is like enforcement, quote unquote, is a separate part of our statute. And I think that lives with the AG's office, but I do get your point of monitoring to ensure that the UPL is actually being implemented, right? So I think that can certainly be part of the UPL monitoring plan. I think that's a great point and something we can look into. One of the, not mitigating factors, but the reason we believe that might be a lower risk is like, this is with our partners that are eligible governmental entities. So we do think that there's going to be a direct line with those eligible governmental entities that we can kind of do kind of our own assessment there. But I think it might be worth articulating something in the monitoring plan. So we appreciate that. Thank you.
Yeah, thank you very much.
Hey, Mr. Snyder.
Andy, first of all, I'd like to echo Dr. Tunis. Congrats to you and the team for putting together a fair process for how to do all of this. I appreciate all the details you shared and all the rest, but I kind of want to go a little bit above that and just talk about a little bit from our perspective of the people that I've been talking to about this. There's a lot of excitement over the potential relief that they might experience by this work. However, as I was looking through all the stuff that you had mentioned, it just made me think about how long it might take between the time that you present your final study and the time when we might have relief. And then you added, we've got to talk to all the counties and the state government to see when they could implement it. I'm really worried about kind of the expectations that we've set for the public that this is going to be something that they're going to see sometime soon. So forgive my impatience, but it feels like it's going to be forever before we ever see some sort of cost relief for people who are having a really hard time right now of affording their medications. So I just wanted to throw that out there.
I think it's a great comment. You're welcome. I encourage you to provide it as a written comment. I think, the board wants to get it right. So I think they've intentionally set up a process that allows for a lot of checks and balances. But completely appreciate your point, and I think we're very receptive to that as well. So appreciate your feedback there,
Andy. But I guess the question is, how do we reset expectations? If this is going to take a while, even talking to the county governments, if they need to have something, if we're going to say that there is an upper payment limit and it can't be implemented for a year and a half because of contractual work or whatever else, that's something important to communicate to the public. We do want to make this right. We do want to make sure that we did it right. We have checks and balances, all that understood. At the same time, we need to tell the public what to expect, because otherwise they're going to lose faith in this process and what we're doing here.
That's a great point. Yeah, we can take that back and try to make sure that we are clarifying our realistic timelines. So thank you. Okay. Mr. Johnson.
Thanks, Andy. I guess if I can, I'll go through each of them. I have a lot of points I just want to ask.
Great,
on the definition, can I just get some feedback from you and the staff maybe? So the definition of purchaser, you exclude patient. I'm just curious, if a patient is paying cash, they're purchasing the product, or even if they have an insurance plan, they have out-of-pocket costs purchasing their drug. So I'm just trying to understand why was patient excluded from the definition of purchaser?
It's a great point. We can take that back. I think we would want to separately define patients. But the way that we are working for eligible governmental entities, those are who we're picturing to be the purchasers. So maybe we can look at, focusing on eligible governmental entity purchasers and then patients. I think we would probably just separately define patients, but we do want any savings to be passed on to patients wherever possible. So that's a good point, and we'll take that back.
All right. I assume purchaser was sort of the state entities because you also had payer. So if it's not a payer, it's not an individual. Who else is out there? So,
yeah.
That's all I had in the definitions. Okay. On the hearing procedures, so similar to what Ms. Schultz had mentioned, when you look at 06B, the general hearing provisions, board shall publish a notice of the hearing on the board's website. I think my recommendation I would have is that you have some minimal time frame that has to be provided. So, it has to be, 5 days or 7 days, no later than 5 or no later than 7 days, before the hearing is when the board has to present this. So just so, again, there's full transparency and there's time, whether people have to be in person, if you're going to have these in person or whatever, so they might be able to accommodate that. So that'd be the one comment. And I guess, if that has to be included some other places, it may not be, because I think B covers everything. So if you had it there, then it would apply also to the technical and the other ones. So I would offer that as something to consider for everybody. And then on the actual regulations. So question about, again, I've raised this before and just want to see if there's any change or any additional thought. Under definitions, you have affordability challenges referred to high out-of-pocket for patients or challenges to the state healthcare system. I know you just mentioned earlier, thresholds might be problematic, but what can you tell us or talk about, how are manufacturers potentially going to know that there's consistency across, one drug upper payment limit or another drug's upper payment limit, that if it was an affordability challenge, how do they know that these were consistently applied? Was one an out of pocket of 10%? Was another out of pocket of 20%? Because, is there a way to get some threshold for what out of pocket may or may not be?
It's a great comment. Yeah, and we've seen that a lot in the comment letters, to your point. So we very much appreciate that. I think my response, well, one, we cite to the statutory definition, so that's why that definition is what it is. And then I'll go over this shortly in our cost review study process regulations. We do kind of articulate what the board needs to say as they are making that determination, right? So we've talked about this a lot before, but there's a number of different circumstances that could cause an affordability challenge as either high out-of-pocket costs or high costs to the healthcare system. So basically, the way we're handling that is that the board articulates that as part of their preliminary determination in the cost review study process. So that's kind of how we've addressed that. Though I would certainly welcome any specific languages that you have. Like, we are extremely receptive to feedback or suggestions or proposed definitions. So if folks have specific recommendations or definitions there, we're certainly open to them.
Okay. Then on the criteria, I had some similar comments that Mandy had, so I won't go into that. But on A, you talk about, or actually it's B, cost of administering the drug, or basically the cost of delivering the drug to consumers. I know this came up in August with, I know the Chain Drugstore Association raised it. I think some of the other folks, the infusion centers, how are you going to address, whether it's dispensing fees or the fact that some of these folks with a UPL may be underwater? So what is the staff or the board's thought to make sure that that's not going to happen? And was there any feedback to those groups in their August comments when they raised some of these issues around those two specific sort of areas of administering and delivering?
Yeah, so it's a great question. And we did see a lot of comments on this. And this is one of the things where we weren't, so our response is that we don't intend for upper payment limits on eligible governmental entities to change reimbursement on the reimbursement side. The way that we plan to implement, and we don't have specific guidelines on this, so ultimately it's kind of up to the eligible governmental entities on the best way to do this. But the way we are conceiving it, and we will be working with our governmental entity partners, is that this all kind of happens on the back end. It doesn't adjust any payments out the door. And that's how we're addressing in Maryland. Again, it's a very specific market for eligible governmental entities. So we don't see this being an issue, and maybe we're kind of misunderstanding how that would happen. But that's kind of our response, is like, to everyone that is not the eligible governmental entity, no one should see anything different for UPLs that are set by the eligible governmental entities. That's how that's the framework that we're using. So now, if it comes up in specific circumstances, I agree, we'd probably want to think through how to mitigate that, but we don't see that being how it would work at this point.
Okay. And then I guess this is, sort of, once things are established and you're going to present, like, for instance, you're going to come up with a methodology and it says, you're going to present that to the public or let the public comment. In those instances, again, I think there should be some minimal timeframes that can be provided. And to some degree, lately we've had a lot of meetings the last several weeks, and these were just put out last week, and now comments are due by Friday. So that's a little bit less than 2 weeks on a very, I know these are sort of draft right now, but when you get into a actual real decision based on methodologies, based on other stuff that's actually going to implement stuff, I think we need probably a little bit longer time frame for folks in the public to comment back. So we can have, I would say, maybe a 30-day process here. And I know the comments before, that this is a long process. Well, it is a very long process. and it's something that's never been implemented in the entire country. So to your point, I think the board's point, if you're going to do it, make sure you get it right. And if it has to take another year, then so be it. But make sure it's done right so you don't have something done wrong and have to come back later. So I would just say, that. And then I did have one other interesting question around the, I guess, suspending the UPLs, changing them and everything. The wording here is very, it seems like if a drug is, correct me, if a drug is on the shortage list, from this, it seems like it is automatically suspended from the UPL. Is that how I am reading this? Is that the correct interpretation of this?
Yes, our statute, so sorry, there's a couple different, I think there's the FDA shortage list. So
Correct.
if a drug is on the FDA shortage list, then it is suspended.
Right.
Yeah.
So if on July, because it goes to the monitoring as well, I guess. If on July 1, FDA says there's a shortage, I understand that it would be suspended there. But if you have a monitoring process ahead of time and you're monitoring, you're getting some information from pharmacists and everything, the way I read this is that it would also be suspended therefore as well, and could also be up for a re-review or something. So I don't have anything in writing, but when I read that piece, it's very, it seemed like automatic suspension, and I don't know if that was intended or not, but it was very, I couldn't follow it, I'll say.
Yeah. No, I think that's fair. And it brings up an important distinction for us. So there's the FDA shortage list, which is a document that exists on the FDA website. And that's what's referenced in our legislation. That's what triggers automatic suspensions. And drugs can cycle on and off of that routinely, right? What I think you're referencing is like this broader idea of shortages potentially just in the state of Maryland, right? So you can see scenarios where there would be a shortage in Maryland that is not for drugs that are not on the FDA list. And there is no automatic suspension there, mainly because there's no kind of definition for it. But what it will do is what we've created a process to do is try to identify it as soon as possible, flag it for the board, and then have them take action on it immediately. So just because there is no concrete specific thing that says there is a shortage in Maryland, for example, outside of the FDA shortage website, we have this process that we have set up, right? So we want to make sure that we are capturing any risk of that as soon as possible, and then it goes to the board as soon as possible, and they can take action as soon as possible. But the only trigger is the FDA shortage list. That's correct.
Okay, because I do see under reconsideration, if the board becomes aware of a shortage,
Mm-hmm.
so this would be, by example, would be prior to the July 1 date. You
Right.
find in April that
Right.
you're aware of something, says the board shall then reconsider the UPL.
Yes.
So it's automatic. Does that mean then it's an automatic reconsideration? Okay.
Yeah, and we'll take a look at that and we'll make sure the language clarifies that. Yeah, and then if they do reconsider it, they have the 4 different or 5 different things they can do. But ensuring that we have a clear enough definition on when it's mandated for the board, we'll make sure we clarify that. So yeah, thank you for flagging.
That's all I have. I know you received the pharma comments, which would be much more detailed and technical, but those are what I had. Wanted to raise those on the call.
Outstanding. Yeah, thank you. And thank you. Agreed. Thank you for taking such detailed notes on such short notice. So we appreciate that. All right. Any other comments or questions? Again, written comments are due on Friday. And again, these are just the draft regulations. So there will be subsequent versions of these regulations published. So you'll be able to see those as well. So we welcome any comments that we have to the stakeholder council's point. We very much value any comments that we receive both from the stakeholder council and the public. So we appreciate the time and effort that folks are putting into that. Mr. Gutman?
Just a general comment. I think others have mentioned this, but it has been such a long time and so much effort that has gone into this, 5.5 years since the law was passed. And the board has just done tremendous work to get to this point, and we see it at the end, at least of one phase in sight. And I just want to congratulate all the participants in this process for helping us get there it does matter whether it's another year or so when things take effect. So please keep that time sense in front of you, as I know you will, and get it done as quickly as possible. But this is great that we've gotten to this point.
Great. Thank you for the feedback. The staff and board very much appreciate it, and we appreciate the stakeholders' time and helping us get here. Thank you. All right, seeing no more discussion on the upper payment limit regulations, we're looking forward to the comments at the end of this week, and we're available for comments and questions for anyone that wants to discuss with us as well. So with that, I will hand it back to the chair. Chair Diana, did you want to? I forget if I go straight into it or if you kick it off.
I would just like to thank everyone for the wonderful, thoughtful comments that you made and the feedback that you've offered, and we appreciate it. So next we'll move on. Andrew and Christina will now give a quick update on the cost review study process.
Great, thanks, Chair Diana. This will be a much quicker update. So as folks know, we're in the process of conducting our cost review on 6 drugs that were selected for the cost review study process. In the September 10th meeting, the board approved proposed regulations to update our cost review study process to account for the new policy review process. So at a very high level, the steps were, select drugs for the cost review study, analyze, and then make their determination on if it causes affordability challenges. What this does is it creates that intermediary step that we can then use later if we publish the upper payment limit, the policy review regulations. They would kind of slot in at this preliminary determination step. So it was important that the board had this preliminary determination rather than a final determination, just so we can use the policy review process on these drugs if they decide to move forward with it. Those regulations were published in the November 1st register. So folks probably saw that that notification come out if you're on our listserv, and it's also posted on our website. And those are proposed regulations, and comments are due on December 2nd, 2024. The next step is then for the board to approve final regulations to be published in the Maryland Register. And the board can take action on the final regulations 45 days after the proposed rule. So after November 1st, that takes us to basically about December 17th. So anytime after approximately December 17th, the board can approve the final regulations. Then once they're published in the regular register, they go live some period of time. I think it's 10 days after they're published in the register. So that's just an overview of the process on these, the regulations that update the cost review study process to allow us to start working on this policy review process. As again, identify that there's affordability challenges. Now we can try to come up with solutions to those challenges. I also wanted to note that those regulations were also submitted as emergency regulations, but we don't have any insights into if and how and when those would be approved. So that's, we don't have any updates on that, but we will notify folks if we do get any information there. The other thing we wanted to note, so staff is working in the background on the analyses of the 4 drugs that we've done the request for information on, as well as there are 2 drugs that we haven't done the RFI on yet, but we are doing any kind of background research that we can do on those drugs. We did ask for additional public comment on the 4 drugs that we did the request for information on. So that's Farxiga, Jardiance, Ozempic, and Trulicity. So our cost review process has an automatic 60-day comment period for when the drugs are posted on the website. So we've already had a comment period come in, but we were hoping to get more kind of clinician experience and, most importantly, patient experience on those drugs. And we didn't get a lot of those comments. And right now, the only mechanism we have to get that kind of feedback is through our comment process. So we've opened the public comments up for another 2 weeks. Specifically trying to get written comment from public members and, or excuse me, patients. If folks have any recommendations on how to reach out to folks, we've been reaching out to different groups that patient support groups and things like that, where we think folks that are directly working with patients that can help us hopefully get to patients. But if anyone has recommendations on how to get better patient feedback, let us know. We are very interested in that. So again, those comments, patients, and I guess one thing I should say, the public is also completely welcome to provide comment during that period. It's not limited to patients. So if you do have additional public comments on the 4 drugs that are in the cost review study process, we always welcome them, and that closes on November 8th. Oh, and then we do have an announcement on the website, so please see our website for information. Other than that, I don't think we have any other major updates. I think, if the board would be taking action on any of these drugs, you would see it in the agenda, but I don't think there's any specific timelines or anything like that. So right now, staff is just continuing to work on those cost review studies. Mr. Johnson?
Yeah, Andy, thanks. You may have just answered my question. So I was going to ask if there was any time frame that you can sort of provide or outline around the dossier for the first 4 drugs. Do we anticipate something at the November 25th board meeting where there could be something on there, or are you still in the gathering phase, given, I guess you want to have some additional patient and provider input? Is it safe to say there probably won't be anything on the November 25th agenda?
Yeah, we haven't posted the agenda yet, so we're not sure exactly what will be on the agenda. I think the staff is working to make sure that the board has all options available. And the board staff has been working on the dossiers on those 4 drugs for the past few months now. So I think we do want to make sure that we incorporate the patient feedback, but I don't think we have specific timelines. I don't think we can say one way or the other on if it would be in the November meeting, but we haven't posted that. We'll post that agenda, I think, on the 8th or
for the next 2, is it safe to say we're probably at least a month out? I mean, so you have the 4,
yeah,
and you're not going to be doing any. Are you going to
yeah, I think I can answer
RFI
this.
after those
Yes.
4 are done? Okay.
I don't think there's no contingency on us posting the RFI on those other 2 drugs. So we can post that RFI before those 4 drugs get an assessment, but we will not do anything with those 2 drugs until we post the RFI. And we don't have a timeline on that yet. It may happen by the end of this year. But yeah, we have not posted those RFIs, and we would not do the board would not take any action on those drugs without going through the full RFI process.
Okay.
I hope that answers the question.
And I apologize, I forgot to ask one other question around maybe the other process, but I know in previous meetings, discussions, you've mentioned sort of rebate pass-through, how it might relate to UPL. Anything, I mean, what are you looking at with respect to rebates, the pass-through process, how rebates currently work in the system versus UPLs? I mean, you've mentioned it, but is there anything further you can give a little bit more context to that, what you're thinking about? Maybe I'm not.
I think I understand the question. So I can just say that when we are the way we have defined an upper payment limit in the regulations is a final net cost to the purchaser, and that incorporates rebates, discounts, other discounts. Like, it's basically the final cost to the purchaser. So one of the mechanisms that you can get to that target price is by adjusting the rebate amount. So that's kind of, I think, part of the framework that we're looking at. Again, it's not a direct one-to-one comparison because the Medicaid program has a lot of very specific rules around it. But the framework that we've been looking at and that we presented to the stakeholder council on the board, probably starting in 23, was the Massachusetts and New York Medicaid programs, where they basically negotiate additional supplemental rebates to get to their target price. And that's kind of the framework that we're using. Again, whether or not that's going to be exactly how it works, I think is still up in the air, but that's the general framework that we're using.
So the context of rebates is in the Medicaid program. It's not in any other it's not in.
Well, we would want to, I can just point to those as examples where this framework has worked, though Medicaid obviously has a very specific rebate structure and rules that they have to follow. But we point to that, but you can picture something similar working in the commercial market, which is how we've framed it up to this point.
Okay. All right. Yep. Thank you. Yep. Sorry to bring that in at the end.
No. Yeah, we're happy to talk that through. I appreciate the feedback there. So, but ultimately, it does kind of work based on how the contracts are set up for each of the eligible governmental entities that would be subject to the upper payment limit. Yeah.
So moving on, Christina, can you give us a quick administrative update, please?
Thank you, Lorraine. The next board meeting will take place on November 25th at 2:00 p.m. This meeting will be in person at the Miller Senate Building. Information regarding this meeting is posted on our website. You may also attend by also you can live stream the board meeting as well on the my MGA YouTube account. So that link is also posted on the website, but you may also attend in person. I would like to give a warm welcome to our newest PDASC member, Nashona Kess. She was appointed by Speaker Jones to represent the statewide Organization for Diverse Communities. Ms. Kess is the Executive Director of the Maryland NAACP. We look forward to your contributions to the PDASC. Welcome. I don't know if she wants to wave hello.
I am here. Thank you. Hi, everybody. We are currently multitasking because we have the election tomorrow. So we have a lot of things going on and getting prepared for the election. But hello, everyone, and thank you. And I look forward to meeting you all.
Thank you. And thank you for everyone for your time today. Lastly, I've been working closely with the appointing offices on appointments that are vacant or that have come up to the end of their term. I appreciate everyone's flexibility as we continue to work through this process. Also, thank you to those who have continued to serve past your appointment terms. We really appreciate it. And then, as Andy mentioned, anything regarding public comment is posted on the homepage of our website. It's actually posted on multiple parts of our website, but if you go to the homepage, it will direct you under the announcements section to more information for those comments. So, be sure to provide comment when necessary. We really appreciate the feedback and expertise of the Stakeholder Council as we continue to roll out these processes. And Lorraine, that is all that I have.
Great.
For
Thank
today.
you, Christina. So we'll wrap this up. Thank you, everyone, for your time and feedback today. The next PDASC meeting will take place on Monday, December 16th, 2024 at 2 p.m. and the meeting will be virtual. Do I have a motion to adjourn?
Move to adjourn.
A second?
Second.
Great. Thank you all for coming.
Thank you.
Madam Chair, I'm sorry, can you just tell me the date of the next meeting again? I think I misput that on my calendar.
Monday, December 16th.
Perfect. Thank you so much.
You're welcome.
And PDASC members, you should have a calendar hold for that date. So thank you.
Thanks,
Thank you,
Christine.
everyone, for your time today.
Bye-bye.